Okay, let's get this started. Welcome, everybody. I'm Wendy Gordon. I'm the chair of the Department of Midwifery, and I'm happy that you're all here today to learn from Brittni Blanco and the work that she has done on her master's project. This is a project that has been going on for a few years, and it's super important work. And I'm really glad that you're all here today to learn from Brittni and the work that she's done and what this might mean for the future of our profession. So with that, I will hand it over to Brittni, and she's going to share her screen and we'll get started.
All right.
Looks good.
Good. Great. Okay. You can still see it.
Yep. Looks good.
Okay. Perfect. So my project is about midwifery education trends. Before I get into what I've done, I just want to make a note on language. First, home and birth center births are commonly grouped and referred to as out-of-hospital births, partially out of convenience. This terminology also tends to characterize home and birth center birth as other, marginal, or alternative. So for this reason, I'll refer to the grouping of home and birth center births as community birth throughout my presentation. There are also various different types of midwives. My project specifically focused on the three professional U.S. midwifery credentials and did not fully encompass the range of midwives that exist globally. My lit review merely touched on traditional midwives or traditional birth attendants. So I just want to acknowledge that this project is just one step in figuring out what role midwives have within the greater context of the maternity care workforce. That being said, I looked at the 4 application routes to the CPM credential that are recognized by the North American Registry of Midwives. There are other routes that I did not discuss here, but I did just hone in on the accredited route. Also, I will use the term midwives and CPMs interchangeably. Lastly, I just want to point out that several reports and data sets tend to use the categories women or female, but in order to be mindful and more inclusive of the full spectrum of identities of the childbearing population, I'll use the term pregnancy capable people in place of the word women wherever possible. And we'll use the words birthing people or pregnant people for the same reasons. So the inspiration for this project emerged from the various reports and articles noting the increasing shortage of physicians, particularly those that provide maternity care, like OBGYNs, family physicians.
Brittni?
Yes.
It looks like maybe I'm the only one, but it looks like we're still seeing the first slide.
Oh no. Oh, it says my screen sharing is paused, but I'm not sure how to unpause that.
How about stop sharing and then start again? Yeah, there you go.
Okay. Start share.
Okay.
Okay. Then I'm just going to get it into present mode here. Okay, that's what's happening. Whenever I go into that present mode, it just...
You can do it without being in the present mode.
Okay, sure.
It still looks great on our screen.
Okay, perfect.
Okay.
Great. Okay, so going back to the issue at hand here. So the graphic here, one of the graphics here states that rural communities, especially rural communities of color, are especially vulnerable to these shortages that I've stated previously. So this all in consideration, a question came to mind. Do midwives have the capacity to relieve the burden faced by OBGYNs and family physicians? Considering certified professional midwives attend just under 2% of births in the US, and I'll go deeper into the data, they also face barriers to integration into the healthcare system. There are challenges to answering this question. So I took a step back. Instead of focusing on the capacity of CPMs, I decided to take a closer look at midwifery education. Midwifery education is one of the 3 pillars of midwifery practice as defined by the International Confederation of Midwives. Education ensures a competent and qualified workforce. And student midwives are the future midwifery workforce. So my ultimate question became, what is the current capacity of midwifery education programs to educate future midwives? So this brings my project. So the aims of my project were to describe the current landscape of the maternity care workforce in the US, and I'll tell you more about who that involves. This included current and projected supply of maternity care providers. I also wanted to review the literature to identify workforce changes, including factors that have influenced those changes, describe midwifery certification trends and midwifery education trends for accredited midwifery programs, and lastly, identify barriers and opportunities to increase the capacity of accredited midwifery programs. So who is all involved when I'm talking about maternity care providers? So I looked at physicians, specifically OBGYNs and family physicians. And as far as midwives go, I focused primarily on certified professional midwives, obviously, and CPMs are certified by the North American Registry of Midwives. They are the only midwife credential requiring clinical training in the community birth setting, and they're regulated at the state level. CNMs, or certified nurse midwives, they first receive a nursing credential, then receive their midwifery education from a program accredited by the Accreditation Commission for Midwifery Education, and they're certified by the American Midwifery Certification Board. They are regulated in all states, Washington, D.C., and the 5 territories. Certified midwives, they are quite similar to certified nurse midwives, but a major difference is that this is a direct entry pathway in which they enter a midwifery education program without having gotten that nursing credential. So they must pass the same exam that CNMs take, and they're regulated in only 9 states plus DC. And traditional midwives. This is a designation that's often applied by national and international organizations and governments, but it's not necessarily how they refer to themselves or how their communities refer to them. The legal status is ambiguous, and traditional midwives are not legally permitted to practice midwifery. So this has potentially negative impacts on recognition and the participation of traditional midwives in the workforce. So now I'll go into what I've found in the literature, starting with the factors that are influencing physician supply. And this is just a condensed version, and there are several other factors out there, and you can definitely read my paper about it. So first things first, healthcare demand changes with birth rates, population growth, population demographic changes. Despite an increase in the absolute numbers of physicians in active practice, healthcare demand is expected to exceed supply of providers. Both the supply of OBGYNs and family physicians has remained relatively steady for the past 2 decades. Several studies are showing that there are high levels of career dissatisfaction among OBGYNs. High rates of burnout and depression are associated with lower career satisfaction, which may lead to earlier retirement. And the workload associated with obstetrics and midwifery can be heavy and unpredictable. Recent studies cite that lifestyle concerns is also one of the top reported reasons that we're seeing these declines in family physicians choosing not to practice obstetrics. And also more US medical students are choosing specialties with a more controllable lifestyle. And with that, the composition of the healthcare workforce is changing. More physicians are nearing retirement, and more pregnancy-capable people are entering medical schools. And they also tend to represent the majority of OBGYN residents. So we're seeing that they're practicing obstetrics for fewer years compared to their male counterparts. Next, we're seeing uneven geographic distribution of maternity care providers. So there's an increasing concentration of OBGYNs in urban or metropolitan areas, whereas family physicians are more likely to provide maternity care in rural communities. However, the overall proportion of family physicians providing maternity care in rural counties is declining. And there's also an increasing trend in OBGYNs relocating to urban counties or counties with lower rates of poverty. And lastly, we're seeing an increasing trend in the number of OB unit closures and a discontinuation of hospital-based OB services in both urban and rural counties. Rural hospitals are disproportionately affected by the lack of hospital-based obstetric services, and OB unit closures are more likely to be in critical access hospitals and low birth volume hospitals. So some reasons why we're seeing this, these closures are difficulty staffing OB units, low birth volume, financial concerns. One possible reason for this might be that there are higher proportions of the population on Medicaid living in rural communities. And so that's possibly contributing to lower reimbursement rates. And then I also want to make a note on maternity care deserts, which is defined as any county that lacks an obstetric provider and a hospital or birth center offering obstetric services. They are classified as having higher poverty rates and lower median household incomes compared to areas with increased access to maternity care. So this map here is from the March of Dimes 2022 Maternity Care Deserts report. And I thought it just gave a good representation or visual of where maternity care deserts are. And you can really see that they're concentrated in certain parts of the US. Maternity care deserts here are in red. So 36% of all US counties are designated as maternity care deserts. 2 in 3 maternity care deserts are rural counties. So now we'll look at what this means and what are the potential consequences of these factors that are influencing supply. So with geographic distribution, there's possibly an increased pressure on family physicians to provide maternity care and obstetric services, especially in rural counties or rural communities. And this could increase their workload, client volume, call responsibilities, and potentially lead to burnout. For OB unit closures and lack of hospital-based OB services, this could mean longer travel times for childbearing people. And in rural counties, this might look like an increase in births in local emergency departments or births attended by providers who are not comfortable with birth per se. And it's also associated with delayed initiation of prenatal care, higher rates of low birth weight, preterm births, and pregnancy-related hospitalizations. And this is especially concerning for the underinsured, uninsured, people living in poverty, and Black, Indigenous, and people of color. And this could worsen health disparities. So I just want to speak briefly to midwives and community birth. So I talked a little bit about CNMs. I want to talk a little bit about kind of how they're one major contributor to how their workforce is changing. Specifically, the number of advanced practice registered nurses in the US is growing. And this does increase access to primary care services, but could potentially result in a decline in the number of registered nurses. So as a result, there becomes a need to replace those RNs as they move on to higher education. But there's more research that's needed to determine the impact that this has on RN supply. Community births in the US are rising, but the vast majority of births in the US still occur in the hospitals and with a physician. We did see a significant increase in the number of community births from 2019 to 2020. This was a 19.5% increase and was thought to have resulted from the COVID-19 pandemic, just seeing waves of people wanting to birth in the community setting rather than in the hospital. This tested the capacity of the CPM profession to take on a higher volume of community births, but there are no published reports on whether this was effective. And while we are seeing more community births, CPMs are likely attending just under 1.19% of those births. National Vital Statistics data reports other midwives and CPMs are likely included in that, but they're not differentiated and those births are not parsed out. So last but not least, there are inconsistencies in regulation. So there are still states where CPMs are not regulated, and this means that there is no path to licensure in those states. This creates barriers to entry to the CPM workforce and integration of midwives into the healthcare system. This integration ensures that midwives can refer their clients and collaborate and consult with physicians efficiently. It improves interprovider relationships and is also associated with better health outcomes. Licensure also supports quality assurance of midwifery practice, and the lack of regulation reduces access to midwifery care, including financial access and limiting of choice of where to give birth. And I just want to make note too of the lack of diversity within the maternity care workforce. There are no reports that describe the racial and ethnic composition of the maternity care workforce as a whole. There are individual reports and surveys that look at OB-GYNs or family physicians, but it's rather limited. And there is a critical need to increase the number of healthcare providers who identify as persons of color, especially as the U.S. population is diversifying. What I did find in the literature, though, is that the majority of maternity care providers identify as white. Among all adult medical specialties, OBGYNs have the highest percentages of providers of color. As far as data around CPMs, there is a need for data that accurately reflects the racial and ethnic composition of CPMs who are certified and practicing. That data is rather limited. There was one article by Cheney and colleagues that surveyed, did a NARM survey, but that was based on respondents and whether or not they responded to the survey. So the response rate was pretty low. All right, so just very briefly want to mention the 4 routes to the CPM credential. The first 2, graduation from a MEEC accredited institution or program, and the portfolio evaluation process, are the 2 primary routes to the CPM. And the other 2 are still utilized, but less so. And we'll look more at the data next. So here's what I did. To get certification data, I contacted the executive director at NARM, and from there was directed to annual reports that were publicly available on the NARM website. Reports span from 2001 to 2021. And I did have to use some personal communication to address information gaps. For MEEC school data, I contacted the director of accreditation at MEEC and asked for individual school trends for the past 5 years. What I did have access to was annual accreditation reports, and these were from years 2019 to 2022. And what this looked like was I did this via email, and I essentially, I sent out my introduction and listed out the data that I was asking for. So now I will jump into the results. So this first graph you're seeing here is the total number of CPM credentials that have ever been issued since the start of credentialing CPMs in 1994. So now we're up to 4,337 CPM credentials that have ever been issued. Here is specifically the total number of new CPMs that are becoming credentialed every year. This is from 2012 to 2021. You can see spikes here in 2013 and 2019. And I'll show you more by pathway, kind of where specifically those spikes were. But generally about 200 midwives are becoming certified each year. We did see a decrease after 2019. This was possibly due to the closure of in-person testing sites for the NARM exam in March 2020 as a result of COVID. And there were also limitations in clinical opportunities that impacted student midwives. So here you can see the new CPMs specifically by entry route. So the Cheney et al. Article that I mentioned previously, the NARM survey, that study found that more than half, just over half of CPMs had utilized the pathway. But as you can see here, based on application NARM application data, MEEK is now the most commonly utilized pathway by new CPMs. I also just want to say that this is just a reflection of how applicants applied to the credential, but not necessarily the complexity of their education. So there could be overlap in how they receive their education, but they can really, this only reflects one way that they utilize and the way that they applied. So for example, like only if you apply through the MEEK route, only people who have graduated from a MEEK accredited school can apply through that route, but they may have previous PEP experience or vice versa. And we see here that, especially in 2019, there was a spike in state licensed midwives. It's not certain why this has happened, but it is possible that this spike was seen because of an expedited application that was pushed in 2019 for state licensed midwives. But after that, the number kind of returned back to where it was. So there definitely needs to be maybe more investigation as to what's going on there or why it is that we saw such an increase there in state licensed midwives. There's also a spike in PEP applicants in 2019. It's also not clear why this has happened, but in that year, or at least at the beginning of 2020, there was the implementation of new US MIRA language in certain states that require new applicants for midwifery licensure to have completed an accredited program or obtain the midwifery bridge certificate. So it's possible that this might have urged PEP applicants to submit their NARM application and sit for the exam before the end of 2019. And as you can see as well, the numbers of, while we do see an increase in the number of MEEK accredited applicants from 2015 to 2018, these numbers are staying pretty much the same now. And the same kind of goes for PEP as well. So this chart is a comparison of active CPMs and CPMs that are not practicing. So within the active CPM category, that's the colored column, the entire bar represents total active CPMs and is inclusive of new CPMs and recertified CPMs. The column on the right, or CPMs not practicing, include expired credentials as well as CPMs who have claimed inactive status, retired status, and deceased. Although those are very, very small numbers for CPM retired and deceased. The biggest numbers that we're seeing here are those that are claiming an active status and credentials that have expired. All right. So now we'll move on to the MEEK data that I found. So there are now eight schools actively accepting applications and enrolling students. The number of schools peaked in 2020 at a total of 12. And at the end of 2022, 3 schools closed. But more information is needed as to why the schools closed. And as you can see by the map, the schools are, it's pretty sparse, but they're mostly located in the West and in Florida. There are no programs or schools in the 5 US territories. And each program is established in a state in which midwives are regulated. So this chart here is just listing all of the actively operating schools. And you can see that there are 5 degree granting programs and 3 certificate granting programs. 2 programs are regionally accredited degree granting programs. And 4 schools offer hybrid education, and 4 offer distance learning specifically for didactic coursework. There's 1 school that offers both a campus option and a hybrid education option. Okay, now looking at MEEC student enrollments, this is total enrollment aggregated across all schools. It's not just new student enrollment, but total. And you can see here that there was a decline after 2019 going into 2020. We don't know why, but it's possible that this was from COVID. But there's been an upward trend in student enrollment since then. Now, this looks at student retention. The mean student retention, you'll see here in the 3rd column, has stayed relatively stable, and it looks pretty good. In the last report that was published in 2022 states a median retention of 84%. But you can see in the final column on the right that these ranges are pretty wide, from 60% to 100%. All right, and then for student completion has been hovering right around 50%. There was a drop to 43% in 2021, but now it's back up to 47%. And then I just wanted to show here briefly comparisons between what I found from the MEEC reports and the 2019 Midwifery Education Trends Report for CNMs, specifically ACME accredited programs. Obviously, there are going to be more numbers because CNMs make up a larger proportion of the midwifery workforce, but just wanted to give you an idea of kind of what's happening on both ends. And these are also different reporting years, so it's kind of hard to compare. But in general, for CNMs, graduates are increasing. There's an upward trend. For programs, there's 37 programs, but trends have been stable for the past 5 or so years. The number of enrollments have been increasing, and they didn't look at retention or completion. But this is just to give you kind of an idea of the comparisons. Oh, and before I move on, yeah, I just want to mention too that graduates, there were 115 MEEC school graduates in 2022. And there was some data missing there. I didn't have data on graduates for 2 of the reporting years. I believe it was 2019 and 2020. So we need more data. So this kind of brings me into what this all means, what I found, and some thoughts that I have moving forward. So we are seeing a decline in the number of MEEC programs, and this limits expansion of the profession. It limits access points for aspiring midwives to receive their education, especially through the MEEC accredited route. Approximately 200 new CPMs are becoming certified each year. And this alone may not be enough to fill gaps in provider shortages. We're seeing that the majority of CPMs are applying for certification through the MEEC accredited route. And there are gaps in the wide variation of in retention and low average completion rates. The reasons for these outcomes need to be investigated. Possible limiting factors based on some reports and studies that I've seen pertaining to CNMs or CNM students specifically, are that availability of preceptors and financial concerns, like the cost of midwifery education and the cost of entry to practice, may impede a student's ability to move forward in a program or enter a program, especially being MEEC accredited. We also are seeing that 30% of all CPM credentials have ultimately expired, but this may not accurately reflect midwives leaving the workforce. There was almost a threefold increase in these numbers in the newly expired credentials between 2020 and 2021. But there could be some inaccuracy with this, just because recertification in some states is not necessarily required to maintain licensure. And so these numbers may not accurately reflect the midwives leaving the workforce. And something of note here too, in regards to preceptors, is that only 50% of active CPMs are registered non-preceptors. And this is in the 2021 report. That being said, MEEC preceptors are not all MEEC preceptors are non-registered preceptors, but all preceptors for PEP applicants must be non-registered preceptors. So there may be some number of preceptors that are not being accounted for because of MEEC preceptors not needing to be non-registered preceptors, or they may not be non-registered preceptors. Yeah, okay. So some strengths of this project was that this is the first known analysis of trends in direct entry midwifery education and capacity of the CPM workforce, which is really exciting. I did run into some limitations. So there were some reports from MEEC that were only available for the past 4 years, and this limited my ability to look at longer term trends in midwifery education. And as I mentioned, I only had 2 years worth of data available for the number of graduates coming out of MEEC schools. And data reported from MEEC on number of enrollments, retention, and completion rates were aggregated for all institutions and programs rather than by individual school. So this provided a limited representation of the variation that exists between programs. So for example, student capacity is highly variable between programs. And so that might impact how we're seeing those median retention rates, and it may not be fully representative of what is actually going on. And NARM and MEEC data did not include data on race and ethnicity for CPMs or midwifery students, respectively. So that brings me to some areas for future research. The reasons for MEEC school closures are unclear and need to be investigated. There might be some barriers to becoming an accredited program. It is a rigorous process and potentially expensive. So there could be a need here for a survey of programs who are not accredited to understand potential factors or barriers to accreditation or why they didn't become accredited. Also, how to increase the number of preceptors. There are several driving factors for CNM student preceptors, as I found in one study that I mentioned previously. And some of these driving factors excuse me, include the lack of financial compensation for being a preceptor. Though the study did find that there was high motivation to take part in training future midwives. There's a need to survey individual programs, as I mentioned, for specific barriers, and also to know what is working. And there was no information available from MEEC about maximum student capacity of programs, nor was there data on the number of filled and unfilled spaces in programs each year. I only have 2 more things left. So graduation and completion trends based on program education formats. Most programs are using hybrid or distance education formats now for their didactic portion of coursework. But these trends in graduation and completion, as it is associated with the program format, might be helpful in determining whether these formats are actually effective. And lastly, studies have identified that racism is a barrier to aspiring midwives of color. And so identifying trends in the diversity of MEEC students would be really helpful. So with that, I have some recommendations. We need to increase the number of MEEC institutions and programs, push for regulation of midwifery in all states and territories, federal recognition of CPMs, and in order to support students and potential preceptors, there needs to be an increase in funding for midwifery education programs. And speaking of funding, there needs to be equitable pay and payment reform. So increasing reimbursement for midwives. Midwifery care is high value and low cost. And last thing, diversifying the midwifery care workforce is definitely important to support midwifery students of color and to support a diversifying population. So I just wanted to thank my committee. So first and foremost, my chair, Wendy Gordon, for all your help. And then my committee, Karen Hayes and Tanya Taiwo, thank you so much for all of the feedback and the input and guidance that you've given me throughout this project. I want to thank my partner, Dylan, my family at home in California, and also my friends here in Seattle. Thank you so much. Thanks for watching.
Brittni, that was incredible. There's hands clapping and all kinds of things going on here on the on the screen. This is such an amazing piece of work and really gives a view into what we need to do as a profession in order to really start to make inroads into the provider shortages and the maternity care deserts and all of the things that the profession is needing right now. Would love to see CPMs stepping into some of those areas, but our capacity to do that is a little bit limited. And your list of recommendations there is just, it's a roadmap for how we get there. So thank you for this incredible piece of work and the analysis that you did. I want to open it up for questions for Brittni. Feel free to just raise your Zoom hand. You can do that by clicking on reactions in the toolbar below, and then click on raise hand. Or you can feel free to use the chat box as well if you would like to type out your request, and I'd be happy to read that for Brittni. So questions. or kudos, congratulations, all of those things too. Ms. Taiwo, Dr. Taiwo, you and your classroom.
Well, they listened and then they all left to go into the sun because it's sunny here and they've been in the classroom all week. So it's just me now. But I just wanted to ask you for the sake of the listeners, how many pages did you write?
Not including my references, 71.
Yeah. And I want to say that, as a person on this committee, I read those 71 pages multiple times. And you would think that, it was like, oh my God, I got to read Brittni's draft, another draft. But really, it was a pleasure to read it every time. And, just watching the whole project unfold from, when it was 10 pages. 20 pages and 50 and then 70, and every time it was like, oh, I learned a lot. And yeah, so I just want to say, thank you for this work. And I hope that there are opportunities for other people, outside of our Seattle community who, get to hear the information that you gathered. And yeah, it definitely the word needs to get out there. So thanks for this work.
Thank you. Thank you for reading all the words and the pages. Oh.
I'm seeing several congrats in the chat box as well. Karen, see you raising your real hand.
Oh, I chatted congrats, but also I'll say it. Congratulations. And same as Tanya. Every time I read it, it was just really intrigued me. And it never got boring. It never got uninteresting. It was just like every paragraph was so full of stuff. And then just watching it all summarized on your presentation, I feel like every bar graph and every bullet point needs more research and more analysis to really understand this. And I feel like it's really timely, and just with the 3 programs closing, which, is devastating, not only for the distribution around the country, but just losing those programs and the unique opportunities they provided for the students who sought them out. I don't know if anybody's doing this, but it would be great to have like a forensic analysis of like what happened, what was strong about them, what wasn't, what was the decision to come to, because I think those would be cautionary tales, and also like, oh, for new programs that might pop up or programs that are existing, what were the strengths that kept them going in good times and hard times, so that that could be replicated. And then also and I think Seattle Midwifery School should be included in that. And FYI, there is a writer and researcher who is writing a history of Seattle Midwifery School. And that's somebody you might want to talk to about kind of what you understand about direct entry, formal midwifery education, so that when she is doing interviews and looking at information and data back from, the 80s and so the olden times, and she's not a midwife, I don't think, but for her to sort of be able to formulate questions and probe themes or issues that you might have addressed that she's not aware of. So anyway, just I can give you her contact information, or
Yes,
Myers.
definitely. Yeah, I mean, it's definitely a complex issue. I mean, there's more. One of I put it in my references slide, but it was very brief. I mean, obviously there are more references, pages and pages of them, but one of the articles by Rayburn specifically just is a huge article about the OB-GYN workforce, with a bunch of facts, figures, all of this, but it's so complex. And there's a lot that I did not talk about because I only had, 40 minutes, but, and also I have to graduate, but, but it's so complex, like everything that influences, the availability of healthcare services, for the population, and then let alone, the childbearing population. So yeah, there's a lot going on and it's constantly changing too.
Right, but I think Wendy used the word roadmap, which is what you've done here, even though it's like, we're not sure, we don't know what this trend means and so forth. Just to have that documented, and hopefully somehow it's going to get disseminated. It just spurs people who may have some of those answers, or who may be looking for some kind of project to do, academic or not, to just start delving into that stuff. It's really, really important. So thank you for providing that to the whole community.
Yes.
There's a great conversation that's been going on in the chat that I will read for folks who can't maybe see that right now. Joni said, congratulations, Brittni. I wonder, is there any kind of organized political action committee that is working on behalf of the midwifery profession who can bring these concerns to the local, regional, or national lawmaking? And to which Dr. Taiwo responded to say, yes, a key organization nationally is the National Association of Certified Professional Midwives. And each state has associations who are working hard to advocate for midwifery. Even those states where licensure is not available, there are advocates who are working hard to support access to midwifery. So that is ongoing, and I will add to that to say, and it's being done by volunteers. So, if someday there was, a tremendous benefactor that wanted to, begin paying midwives to be doing that political advocacy work, I'm sure it would be appreciated. But really, it's all done by volunteers at the state and national level. As some of you probably know well, midwives we're not a profession that is flush with money that we can use to hire lobbyists, for example. So there are some states, and there was at one point, for the National Association of CPMs, a paid lobbyist who was working at the federal level, but they are very, very, very expensive. So it is a challenge for midwives to do that kind of work, but we do it and have done it for decades. But it's all on a volunteer basis. Okay, any other last questions or kudos for Brittni before we wrap it up for this hour? Well, we'll give one last round of applause then. Congratulations, Brittni. You did it. You did it. And this was great work. Super proud of you. And thank you for all of the hard work that you did for the profession in this regard. It's a tremendous report, and I think we'll get lots of traction in many areas. Yeah.
Amazing. Thank you so much for watching, everyone.
All right. Enjoy your day. Have a great
Okay.
weekend, everybody.